Hello, and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. GP Online is the official media partner for the RCGP annual conference, and this is our second special episode from the event at the end of what has been a very packed day one. Coming up in this episode, I'm talking to Dr Victoria Tzortziou Brown, the RCGP's Vice Chair for External Affairs, and Dr Micahel Mullholland, the college's honorary secretary, about what went on at the conference this morning, in particular what RCGP Chair Professor Kamila Hawthorne had to say in her speech. We're also talking about health inequalities, continuity of care, and what the college wants to see in the government's 10-year plan for the NHS. Later on, I'm speaking to the college's safeguarding lead, Dr Joy Shacklock, about the new RCGP safeguarding standards which have been launched at the conference today and what they mean for GPs and their teams. And I'm talking to Dr Catherine Millington-Sanders, the college's clinical lead for palliative and end-of-life care, about the RCGP and Marie Curie's Daffodil standards and how they can help practices to improve end-of-life care. These special episodes of Talking General Practice at the RCGP annual conference have been supported by Copperfield. Copperfield are the UK's only youth-focused breast cancer awareness charity, and they're on a mission to get every 18 to 24-year-old checking their chest. Copperfield educates people on the signs of breast cancer and encourages them to check their chests monthly, so that if they notice something unusual for them, they are empowered to contact their GP and advocate for themselves. Copperfield also provides resources and e-learning to healthcare professionals to support them in encouraging breast awareness with their patients. For more information, visit copperfield.org. So the first speech of the day today was from Professor Kamila Hawthorne, the RCGP chair, who spoke about the pressure GPs are under and concerns about how many GPs are considering leaving the profession. She also highlighted new research from the college that shows GPs in some of the poorest parts of the country are caring for significantly more patients than those in more affluent areas. She also had a challenge for the government, saying that the 10-year plan for the NHS, which is due to be published next year, needed to deliver on promises to provide more funding for primary care so that we can create an NHS fit for the future. Here's what she had to say about inequalities.
When I began in general practice a long time ago, it was normal for a GP to have a list size of between 1,600 and 1,800 patients. The role was busy and challenging, but it was manageable. Our analysis of the latest figures reveals the average is now 2,300. The numbers have shot through the roof, and so has our workload. And it's not just because the patient-doctor ratio has got worse, it's because at the same time the needs of our patients have become more complex as the population ages and many more people live with chronic diseases. I know this is an inelegant term, but what this means is that most people are now under-doctored. More worrying, in areas of higher deprivation where the need is greatest, we've uncovered evidence of how much worse that ratio has become. Our latest research has revealed that GP practices with the highest level of income deprivation have far greater number of patients to care for than those in more affluent areas. The most deprived areas have one fully qualified GP to cover 2,450 patients. That's over 300 more patients than in GP practices with the lowest level of deprivation. And these are the average figures. In some cases, the discrepancy is even more stark. It can't be right, for example, that a GP in leafy Kingston upon Thames looks after just over 1,800 patients, while a GP in Kingston upon Hull, one of the most deprived places in England, is expected to cover twice that number. This situation has become more challenging for all GP practices since 2018, and we would argue almost all now are under-doctored. It is simply wrong that the most disadvantaged communities have seen the numbers of patients per full-time equivalent GP increase by nearly twice the rate of those with the lowest level of deprivation. It is more than 50 years now since Dr Julian Tudor-Hart, a famous fellow GP from South Wales, who I had the privilege of knowing, first defined the now famous inverse care law to describe how, perversely, people in deprived communities who need healthcare the most are least likely to receive it. How devastating that nothing much has changed. I've worked in areas of high deprivation, and I know how poverty leads to health inequalities. From the outside, it might look as though young doctors don't want to work in disadvantaged communities, but nothing could be further from the truth. Newly qualified GPs are showing a huge commitment to working in areas where the need is greatest. In fact, what's happening on the ground to our newly qualified colleagues, it's a scandal. At a moment when patients are struggling to get appointments and GPs are struggling with the pressure of work, new GPs are being trained but not able to get jobs. Our survey of GP registrars due to complete training between July and September of this year found that almost half of them still hadn't got an NHS GP job. The vast majority said they were struggling to find an appropriate role and on average had applied for 13 jobs each. And guess what? GPs are struggling hardest to find roles in areas that have higher levels of deprivation, potentially further entrenching health inequalities. I think it is unforgivable that the poorest communities are once again being hit the hardest.
Some of the issues Kamila was talking about in her speech reflects topics we talked about when I spoke to her for yesterday's episode of the podcast. So do have a listen to that interview if you haven't already. I'm delighted to be joined now by RCGP Vice Chair for External Affairs, Dr Victoria Tzortziou Brown, and the college's Honorary Secretary, Dr Micahel Mullholland, who've joined me in my little room here at the conference. So thanks so much for coming to speak to me, both of you.
Thank you for inviting us.
Thank you.
This morning, we've just come out of the first main session, and so there's been a lot of focus on health inequalities this morning, in particular inequalities experienced by people in some of the poorest parts of the country. And in her speech, Professor Kamila Hawthorne spoke about new RCGP research which shows that GPs in deprived areas are responsible for significantly more patients than those in affluent areas. But it's quite important to stress that this isn't because GPs don't want to work in those areas, is it? Those are some of the places where newly qualified GPs are struggling the most to find work. So what is going on with all of that, do you think?
I think what we're seeing is some of the areas are getting the incentives to get trainees to come to them, and then as soon as they're qualified, they're really finding difficulty getting jobs there. The funding and the practices in those areas is not sufficient to employ the staff and the GPs that they need to provide the care where we know people have increased health needs. So it's a vicious circle where the people don't get the GPs they need, their health gets worse, they still don't get the GPs they need, and the healthcare deteriorates because of that, and their health deteriorates.
Yeah, I mean, this is part of the college's one of your big pushes as well, isn't it? Is to sort of get more funding into practice in deprived areas, so shift the balance of funding so that deprivation is better reflected in the way practices are funded, aren't they? What would you like to see happen?
Well, from my perspective, I'm quite pleased that this has been highlighted because it brings to the fore what those of us working in areas of high deprivation and stark health inequalities have known for quite a while. So we see more complexity. We see people with multimorbidity. It takes a lot more effort to deal with the needs that patients have in these areas. But at the same time, practices receive less funding, and we have less GPs, full-time equivalent GPs, for the population that we serve. So what the college's position on this is that, first of all, the funding needs to be reallocated. More funding needs to come in areas of high deprivation and health inequalities. But also the workforce allocations need to be rethought through. We need to incentivize people. We need to welcome people to work in these areas and also support them because, as I said, it's quite challenging.
One of the other things Kamila mentioned in her speech as well, she really stressed that the 10-year plan for the NHS, which is expected next year, it really needs to deliver on those government promises to put more money into primary care so we can start to see this shift away from hospitals. She also talked about how important it was that the plan was created with the involvement of GPs. I mean, what would you both like to see in that 10-year plan next year?
I think the big thing that we need to see is that funding is moved from hospital to general practice, where we know we have 90% of the consultations in general practice. We get 10% or less than 10% of the NHS budget. And as our consultations are rising in complexity all across the country, particularly in the areas of health deprivation or social and economic deprivation, we need to have more funding going into those to actually deal with that. And then we can employ the colleagues that we need. We know there are GPs struggling to get jobs at the moment, which is just crazy when you have a world where patients need GPs are wanting work, and we can't employ them because of the funding difficulties. So more money into general practice is going to be the thing that starts that off and gets patients seen more quickly, more easily, and GPs feeling more satisfied.
Is there anything else you would like to see in there, Victoria?
Yeah, an emphasis more on workforce planning, I think. So we do know that we train more GPs than ever before. However, we cannot retain them at the moment. So there has to be an emphasis on retention. We have to pilot new initiatives and see what works. We need to work with our newly qualified GPs and find solutions.
One of the other people who was speaking this morning was Professor Kevin Fenton he's the president of the Faculty of Public Health, and he was speaking about public health quite generally, but also the important role general practice has to play as part of this. I mean, he was also talking a lot about health inequalities. I mean, I thought his speech was brilliant, but what was the key thing you took away from what he had to say?
I think it was at the ending when he got to the bit about the strategic interplay between health inequalities and preventive health. And I'm leading the college's clinical priority on preventive medicine at the moment. We've just started a 3-year clinical priority. And that really resonates, that if we can improve the prevention side of healthcare and get GPs and our patients starting to look at how they prevent the illnesses, it will actually transform the way we can actually help patients across all of those divides and the social determinants. We can start to reverse them, because when you see the figures that he presented, where the average length of life spent with morbidity and sickness, and actually the length of life being shorter in populations with social inequalities, it really is a wake-up call to us all that we need to address things in a radical new way that isn't just treating the sick when they get sick, but trying to prevent more of that illness as it happens.
I would support prevention provided it's evidence-based. So there are a lot of interventions that present as prevention, and at the moment there isn't very much evidence behind those. So we need to be quite careful when we talk about prevention to be specific and focus on evidence-based interventions. Otherwise, we can increase over-medicalization, which actually is one of the factors that increase spending in health. Unless we pay some attention to that, it can get out of control.
Kevin Fenton was talking about at the end was some quite interesting work going on between the college and the Faculty of Public Health. It sounds quite interesting, like mapping the public health skills framework to the RCGP curriculum. Are you able to talk about that? Why is that happening and what's the aim of it?
I think it's happening because we know that there's a lot of GPs that have an interest in public health, and a lot of what we have in our curriculum has resonance with public health and population health initiatives. The public health doctors on the other side and the public health faculty are saying that a lot of their work actually has impact primarily through community and general practice. And as we've looked at the curricula together with Health Education England or NHS England, we see that there's lots of bits that overlap. And in fact, we're thinking of how we get dual training up so people could train over a longer time in both specialties at once. So we'd have jointly qualified doctors in public health and general practice. So it's quite exciting as to where that would end up. We know there are already some doctors that do it, one specialty after the other. But to try and improve that pathway, it's trying to put the two together and have a slightly longer but combined route to specialisation.
Yeah, that sounds really interesting. I've already earmarked that for a possible podcast episode for later. And then the other person who was on the main stage this morning was an interview with Jacob Lant, the Chief Executive of National Voices and former guest of this podcast. He was talking to Kamila, and National Voices is a coalition of health and social care charities in England. I mean, one of the things he was talking about was this kind of balance between access and continuity and how hard it is to get that balance right. He was talking about trying to influence policymakers to think about access as much more complex than just numbers of people through the door, which is obviously really important, and maybe measuring general practice based on outcomes rather than outputs. I mean, what's your view on that? Do you think an approach like that could work?
There is a disproportionate emphasis on timely access at the moment. Rather quick access, not even timely access. And I think that takes away the attention from what matters, which is other aspects of quality of care, including continuity and trust and relationships. There is already research coming out that shows that when there is continuity of care, actually access for patients becomes better and demand for services also improves. So there is a need to focus on quality and maybe identifying other outcomes of quality that we need to pay more attention and put more energy towards to.
I think there's lots of measures of continuity that we've looked at, and as a college we worked closely with the Health Foundation a few years ago to look at different models of continuity across the country. And I think that bit that Jacob referred to as episodic continuity is something that patients increasingly want, that some patients really want a quick in and out, sort my problem. For others, it's long-term continuity when they're possibly older age and they have multiple chronic morbidities going on. But for some, it's an episode of care, whether someone's had a new diagnosis of cancer, they have a mental health problem, there's stresses in their family or whatever, and we need to look at how we can apply that. But it's a real challenge in the mix of ways we now consult, and with online triage being a way into general practice for a lot of patients, it's hard for us to start that continuity journey when someone's having to start off with an anonymous email. And for practices, I think it's a real challenge to build the systems behind that allow the patient to get the continuity they need after their first e-consult.
Yeah. It sounds like the government is going to really push continuity as a big thing potentially, and potentially in the next GP contract. It sounds like that's something that's under discussion at the minute. How do you both feel about kind of continuity becoming part of the contract? Do you think it's actually even possible to put it in, and is it able to, will we be able to measure it in any way, shape or form at the minute?
Yes, there are measures that we could use, and I think that would be a good start. And starting to understand continuity and where we are would be a sensible thing to do. The college is more reluctant to support very simplistic targets for continuity, because all these things, simplistic targets can have unintended consequences, as we know. We need to understand which parts of our populations benefit the most from continuity, try to respond to those needs, working with our patients and our communities, as both our speakers said this morning.
What was it that Jacob said? He was saying that it would be something like you could ask patients a question, couldn't you? Patients with long-term conditions management, like, are we helping you to live the life that you want? I think he used that could be a really good starting place to measure how well we're doing long-term conditions, rather than focusing on things like maybe elective activity and stuff like that. I mean, did you think that was quite a good idea?
Yes, absolutely. I mean, National Voices did express really elegantly what is personalized care, which is about helping patients and their carers to live independent lives and achieve the outcomes that are important to them.
Obviously, very early time in the conference so far. What are you both most looking forward to over the next couple of days?
Personally, I've got a few things that I'm involved in. So we've got safeguarding. The college is launching its new safeguarding standards, which the next session I'm at. But I think all of us are looking forward to Wes Streeting appearing tomorrow, and the questions that are going to come to him, and to hear how he answers it, and to hear behind, as Kamila said, the words are great. What we need to know is how he's going to do these things about increasing the funding going into primary care or community care, and what that actually means for general practice. So I think everybody's sitting waiting for that, and that's tomorrow morning.
Yeah, it's good that he's coming though, isn't it?
It's fantastic that he's here. And it's really good that we're one of the first conferences, one of the first groups of the health service that he wants to engage with, which is an encouraging start in itself. And tomorrow we just want to hear the details, or more detail behind what he said already.
Victoria, what are you looking forward to over the next day or so?
I'm really looking forward to all the sessions I chair, which are on health inequalities, of course, research, which is so important if we are to find the solutions that work, but also more practical sessions on triage and interface working with the hospitals.
Okay, that's brilliant. Thank you both so much for coming to speak to me. Thank you.
Thank you very much.
Thank you.
Today at the conference, the RCGP launched its new safeguarding standards and a new toolkit to support GPs and the rest of the practice team with the standards and safeguarding work more generally. Ahead of the conference, I spoke to the college's safeguarding lead, Dr Joy Shacklock, who spent the last 2 years developing the new standards, about why they've changed and what the changes mean in practice. Thank you so much for speaking to me today, Joy.
No problem. Thank you so much for having me. It's really exciting to be here to talk about this project.
So you're running a number of sessions at the annual conference this year on safeguarding, presenting details about changes to the RCGP safeguarding standards. So firstly, why have the standards changed?
Well, I think the first thing to say is when we talk about safeguarding standards in general practice, we're really just talking about the holistic care that we give to our patients. And general practice is a key part of that whole system approach to safeguarding. And it is therefore important that we know how to do that most effectively. And that's why we have built the standards. The standards for safeguarding knowledge and competencies and training for all healthcare staff in the UK have been around for many years, actually. So safeguarding standards in themselves aren't new, but they have previously been set out in separate child and adult intercollegiate documents for safeguarding. We wanted to take in the college a really bold new approach to safeguarding learning in general practice. We wanted to ensure that safeguarding remains a priority in general practice, as well as moving to a more adult-based learning approach to safeguarding learning. And then back in 2021, the RCGP Council passed a motion that any future safeguarding standards for general practice should be set out by the RCGP, specifically for general practice, rather than the intercollegiate process. So over the past 2 years, we've been on an extensive journey to develop the new standards, as well as new safeguarding resources. The ultimate aim of our work is to empower and enable GPs and the whole general practice workforce to be competent and confident in safeguarding children and adults. Victims and survivors of abuse are frequently in contact with general practice, and it is really important that they receive a compassionate, competent and appropriate safeguarding response from general practice, regardless of where they live in the UK or which general practice team member they are seen by.
What are the key changes to the standards that GPs need to be aware of?
So firstly, the thing that hasn't changed is the importance of safeguarding. As I've just mentioned, we've all got our part to play in both preventing abuse and neglect from happening in the first place, as well as stopping it when it does happen. And effective safeguarding requires a multidisciplinary and multi-agency working, together role, and that will continue. We then, secondly, wanted to change the narrative and develop the narrative around safeguarding, and particularly around safeguarding training, which, because of a sort of more hours-based approach, had sometimes become a bit more of a tick box exercise rather than meaningful learning that impacts people on their day-to-day practice. And the new standards utilise and build on the key skills that GPs and general practice staff already have, such as listening, empathy, professional curiosity, having difficult conversations, working with others, and being an advocate for our most vulnerable patients. The new standards outline safeguarding knowledge and capabilities across 5 key areas, which are professional responsibilities, identifying abuse and neglect, responding to abuse and neglect, documenting safeguarding concerns and information sharing and multi-agency working. It's a single life course document, so it includes children and adults in the one set of standards. It covers all GPs and everyone working in the general practice setting across the 4 UK nations. With regards to safeguarding learning, the biggest change, and the one which we know will please many people, is we have removed the hours-based safeguarding training requirements. So GPs will be familiar that they used to have a certain number of hours safeguarding training, and we have removed that, and we now focus on safeguarding learning through reflection and changing practice. We now recommend an annual safeguarding update for everybody working in general practice. And for those who require level 3 safeguarding training, so that is, so mostly our clinical staff, there's also a focus on engagement and learning and reflection. And we've outlined that safeguarding learning can come from a really wide range of sources. So it can be case-based learning, it can be attending your practice safeguarding meetings, it can be safeguarding courses, and of course multi-agency safeguarding learning events as well.
Are there any key changes practices will need to make to their policies or processes, for example, to ensure they're following these new standards?
For many people, nothing will change straight away. I think aspects of safeguarding will still remain the same. But in terms of thinking ahead, practice and organisations will perhaps want to first review the standards and then consider if their safeguarding policies or procedures need to be updated. One of the key areas to consider will be induction of all staff and how safeguarding is built into this for every induction. One of the new things in our toolkit is that we have a template to support induction and safeguarding in general practice. This template outlines the local knowledge required for effective safeguarding, such as who do you ask about for safeguarding advice. Practices might, and individuals as well, might then want to consider how safeguarding is embedded into your day-to-day practice and where there might be gaps. One of the new elements in the standards are that we have specific safeguarding knowledge and capabilities for practice managers, and this reflects the importance of this role in general practice, in particular with things like safer recruitment, embedding safeguarding culture, and of course supporting staff who themselves may be victims of abuse, such as those who are experiencing domestic abuse at home.
You've also developed some new resources to accompany all this work on how they can help GPs and other members of the practice team.
Absolutely. We're really excited alongside the standards to be able to launch a new safeguarding toolkit. We've tried to make the toolkit a one-stop shop for safeguarding in general practice, and we have tried as much as it is possible to make it relevant for wherever you work as a GP or wherever you work in general practice across the 4 UK nations and different settings. One of the important things to say is that the toolkit doesn't set out prescriptive ways to safeguard. Rather, it sets out principles and guidance for how to approach safeguarding concerns, as each situation is unique. It sets out the different types of child and adult abuse and signs to look out for. It then sets out how you should respond to those concerns, including in situations where you're not sure, and often we're just not sure. One of the new topics, I guess, that we cover in the toolkit is something called transitional safeguarding. And this relates to young people in their teens moving through to young adults. And increasingly, services are looking at how they support young people like this into adulthood and making sure they have the same protection from harm when they are 18 or 19 as when they were 16 and 17. And obviously, general practice, we can play a key part in this. We also have a section on assessing mental capacity in complex safeguarding situations, such as where there's self-neglect or where there's drug and alcohol dependence. We know that these situations particularly can be really tricky. But what I would say is go and have a look at it. It can be utilised in so many different ways, and it's there for you to dip in and out of it as you need to. Or if you're not sure whether a situation you're involved in with a patient at the minute is a safeguarding concern or not, again, you will find guidance in the toolkit to help you work through that. We've worked with the Centre for Expertise on Child Sexual Abuse to develop a resource on helping practitioners talk about child sexual abuse. We know this is one of the most difficult areas that practitioners face, and people can feel really worried about how to approach it. And then the other example would be the information sharing guidance that we have produced. We have worked really closely with the Information Commissioner's Office and the GMC as well to develop this resource to make it a robust and really clear resource for practitioners on how to share information effectively to safeguard children and adults. We also have some new e-learning as well. So we've developed 3 new e-learning modules on core safeguarding in general practice as well.
One thing I hear a lot from GPs when I speak to them and when I've been at various events is that safeguarding work has become increasingly complex in recent years. And this is obviously, as we've been talking about, like a really important issue. Is there any key advice you can give to GPs and practices that could help them in their day-to-day work on this?
So first of all, I really want to say thank you to all the GPs and general practice teams across the 4 UK nations who already do so much to safeguard their patients. We know often going above and beyond to make sure their patients are safe. But we know absolutely that safeguarding can be really complex and take significant time. One of the privileges of my role in the college is that I get to speak to lots of GPs across the 4 nations. And what's interesting is everyone has a safeguarding story to share. These are the cases that stay with us as professionals often, but often what shines through for me is how GPs and everyone in general practice want to do the best for their patients when it comes to safeguarding, even though there can often be significant frustrations with safeguarding systems across each locality, really. All agencies are trying to do their best with not enough resource, and that presents challenges, of course. I think there are probably 3 key things to have in place which help the process. First is embed safeguarding in your day-to-day practice, whether that is as an individual or as an organisation. Always consider abuse and neglect as a potential cause for any presentation in general practice. Abuse and neglect can impact health in so many different ways, hence why we see so many victims and survivors of abuse in general practice. Don't be afraid to ask about abuse, but at the same time, be mindful that victims of abuse will often not be able to tell you verbally that something is wrong. And particularly when we think about children or perhaps adults with profound learning disabilities, for example, learning to be able to spot the signs of abuse and respond appropriately is so important. We know that professionals worry about getting it wrong when it comes to safeguarding, but in health, we often think in the opposite way, don't we, when it comes to other life-threatening conditions such as cancer or severe mental health or severe acute illness such as meningitis. With these conditions, we tend to want to make sure we're ruling them out because we know that early treatment is so important or that patients may die if we miss a serious condition. And we need to apply the same mindset to abuse and neglect. We know that, sadly and tragically, children and adults can die from abuse and neglect, or there can be lifelong devastating and catastrophic effects. So just being able to think, actually, what if I'm right? rather than what if I'm wrong, what if I'm right, is a really kind of good way to approach it. Embedding safeguarding also means it is equally important to look after yourself and your colleagues and everyone's well-being. Being involved in safeguarding situations can be upsetting and stressful, so having support systems in place is essential. The second is being really clear where you can get safeguarding guidance and advice when you need it. Practices and organisations should make this information easily available and accessible for you. If you don't know, ask. We've got a template in our toolkit which outlines the local knowledge you need to be able to have to effectively safeguard your patients. Make it a priority to know where to find this information, because then at 4:00 on a Friday when you need it, you have it immediately to hand. Never feel like you're on your own with safeguarding. There is always somebody you can talk to. One of the things that we have put into the toolkit is 9 key questions, and that will sit at the top of our kind of new safeguarding hub. And those are key questions that if you're in a situation and you don't know what to do, that you can go there and you can get some guidance instantly. And it doesn't set out local guidance or anything like that, but it's things like, well, how do I know if this child or adult's been abused? I don't know if I should share this information. Where do I get my local social services number? And it sort of talks you through how to find those things. So that can be really useful. And then lastly, have processes in place to manage safeguarding across the whole practice and organisation. Safeguarding isn't one person's responsibility in general practice, it's everyone's. And effective safeguarding involves the whole practice team, so it's essential that everyone is involved. So for example, having administrative teams who can, manage safeguarding information safely in and out of the practice, as well as being able to do a lot of the safeguarding coding and medical records, is enormously helpful. Another example would be ensuring that safeguarding is regularly discussed at practice meetings and embedding a culture where every staff member feels confident in sharing any safeguarding concerns, no matter how small, and asking for help and advice when they need it.
Thank you so much, Joy. That's great. Thank you.
Thank you so much for having me, and I look forward to everyone looking at the new resources.
Thanks so much to Joy there. We've put a link to the new safeguarding standards and the toolkit Joy mentioned in the notes for this episode. Providing care at the end of life is an important part of a GP's role. For a number of years now, the RCGP has partnered with the charity Marie Curie on the Daffodil standards, a free evidence-based framework to help practices self-assess and improve the end-of-life care and bereavement care they provide to their patients. I caught up with the RCGP and Marie Curie National Clinical End-of-Life Care Champion Dr Catherine Millington-Sanders to talk about how the standards work and what needs to happen more generally to improve end-of-life care. Thank you so much for speaking to me today, Catherine.
Thank you. It's a pleasure to join you. Thanks, Emma.
As I mentioned there, you're the RCGP and Marie Curie National Clinical End-of-Life Care Champion. Can you explain exactly what that role involves?
So first and foremost, I'm a GP in South West London and Surrey, and it's a fantastic opportunity of being able to reflect what I do in general practice and then being able to think about what other GPs and primary care teams need around the country. And there's lots to it, so there are different strands. So one really important part of the work that we've delivered is about developing the Daffodil standards, which are the RCGP and Marie Curie advanced serious illness and end-of-life care standards for general practice. And what that looks to do is give all practices around the country, whatever your level of starting, it doesn't matter, to be able to give quality improvement activity across the whole end-of-life care pathway, from identification all the way through to helping and supporting someone after they've died. That's really a huge part of the role, is making sure that every practice around the country hopefully eventually gets signed up. Currently, we've got about 1 in 5 practices signed up around the UK. Trying to help and support practices and teams, it's such a glorious thing to be able to do, and to see and hear some of the stories that people are doing fantastic work around the country is really, really inspiring. Another part, we work with policy teams to be able to raise the profile, help them lobby for really important things, such as simply, I think most teams will know this around the country, that there's not enough funding in general practice and not enough resources. And really trying to lobby to ensure, just to get the best possible end-of-life care, it makes common sense that you need that support and resource in the system in primary care, as well as in the acutes and the other sectors. And also helping teams work together across those sectors is an important part. And then another part is really just building relationships with different important organisations and stakeholders and making sure that we can sort of share and collaborate together.
You mentioned the Daffodil standards. They've been around for quite a long time now, haven't they? So if a practice signs up to do that programme, what exactly does it involve?
It's super simple. There's a website, the Daffodil Standards, then you can get onto the RCGP site, which gives all the information. It gives a little intro and then all the tools and resources. So everything that you need is on the webpage for the Daffodil Standards. And there's just a little sign up. And so you can get the newsletters and things, which are on a regular but not too frequent basis, which everybody will be pleased about. And then you get a lovely pack from Marie Curie with lots of lovely information and bits and pieces in the post. But the actual technical information and pack that you need to physically start the journey, like your audit tools and your MDT templates, different sort of carer feedback surveys and things, it's all online. And so once you're signed up, it just helps us make sure you've got what you need, keep you update with some of the tips that come along, normally on a monthly basis, some webinars and CPD. Super simple. I can't encourage it enough. Come and join our community of practice.
The Daffodil Standards, they're very much based around a team approach, aren't they? About getting the whole practice team engaged in it and doing the quality improvement activity together as a team. That's quite an important element of it, isn't it?
It's vital. We all get to think we're doing a lot of this already. And if you're thinking that listening, you absolutely are. What this really helps is gives you a structure so you can test yourself and you can have a look and go, where could I do it better? Because let's face it, we could all do bits in our practice better. So you've got diagnostic tools like a bit of an audit, again, super simple, or you can track it using an MDT template. And you can test with information about what are you collecting? Are you making a real difference where you think you're making that difference? And just asking with a few questions, what could you simply do? Because often it's really super quality improvement activity, like being able to send out to all your patients who, or the families of people who have died, some form of condolence message, because we know from the evidence that that makes a big difference on families' journeys. It's what they remember and what lives on with them. Doing a tiny thing to find out how many people have you actually sent that to who have died in the last 6 months. Have you done everybody? Would you have been able to? So super simple things, whole team approach, because GPs don't need to do everything. We've got fantastic team members, and little simple things can be done by, someone else that takes the lead, like a receptionist, a carer's lead that can do these things, and also gives them real sort of job satisfaction in being able to make sure they're part of that team, giving the very best end-of-life care and bereavement support to families and patients.
The Daffodil Standards also have an annual awards programme, and this year's awards are being presented at the RCGP conference here. So can you explain a little bit about what the awards are and why Marie Curie and the RCGP decided to set these up?
The awards are very close to my heart, so we've just been judging them. I know they're hot off the press, so I won't let the secret out. But they're really an incredible inspiration. Literally yesterday we were on the judging panel and we had these fantastic nominations from lots of categories, and hearing the magic and the really fantastic work that people are doing and then being able to share that, I think it just raises all the goodness of general practice, because so often there's negative things about general practice and we don't talk about enough what fantastic things we actually are doing for patients and families. It's really wonderful. And this year, for the first time, I had a patient's family contact me via Twitter after they saw one of the tweets. They asked, how can I nominate my practice and this particular team member, because they're awesome. So just being able to share the love and the joy of giving really fantastic end-of-life care in general practice is something I think we should all be proud of and talking about and supporting our colleagues and celebrating each other. And the awards personify that.
Marie Curie recently published a report on better end-of-life of care, which is based on the experiences of people affected by dying and death and bereavement in England and Wales. And the report highlighted some real problems. In your view, what are some of the key challenges we're facing at the minute when it comes to end-of-life and palliative care?
One of the key parts, in order to be able to give really good end-of-life care, it makes common sense that you need people to be able to have rapid access. So someone that is in pain or is in grief or really needs some emotional support, whatever it is, patient or the family, you need to be able to access your GP. You need to be able to access services that you need to in order to be able to support the patient and the family. And then you need to be able to sort of get medication simple things as quickly as possible if you've got some of those symptom issues. You need to be able to get support and advice. How do you get that quickly? There's variation across the country. There's gaps in care. So the 24/7 aspect. So we've got in-hours GPs. We've got variation about how out-of-hours services. So how is a person really supposed to know how to traverse that and how to make sure they can get the best care? I mean, general practice is renowned for being able to try and offer the coordination of care and that continuity of care. I think there's a lot about how we just coordinate that for people. So there are obviously shared care records. There's variation in what those shared care records look like. So you can pass the baton of trust as a GP onto the hours service if you happen to get sick in the middle of the night. So I think trying to look at all these multifaceted issues, when you're trying to link all of those things together, it becomes easier, you can see, to get gaps in that care. But undoubtedly, in my mind, trying to get increased funding and support and resource, particularly in general practice, which I think has been disinvested with over the years, I think that's vital. Because if we don't physically have enough people to see, go and do home visits, that's sort of fundamentally one of the most important. Our colleagues of pharmacists and hospices, making sure they've got enough funding, sustainability funding for them to be able to survive. When you've got very complex pain symptoms and control that need specialist input, there's a huge list. The report has been so vital to be able to help us lobby for the very best end-of-life care, because fundamentally, everybody deserves to have a good death, a good end-of-life care in the journey for the bereaved people after that. So being able to fight for that, Marie Curie is a fantastic advocate for it.
A big part of providing end-of-life care in the community and in general practice is also about supporting carers and families. And, you know, for GPs and their teams, that often means they'll be continuing to support those people after their loved one has died. So what advice can you give GPs and practices about how to do that effectively?
I would definitely advise them to sign up to the Daffodil standards. And then online, there's a fantastic plethora of awesome tools and tips and things that you can do that take you through the whole, from carer support, carer identification, all the way through to bereavement and care after death. There are lots of things that you can do. We've mentioned sort of bereavement cards and being able to sort of make sure that someone's acknowledged that they've had a death. But there are great support tools. You can also ask a few, even if it's on a bereavement call, how did we support you as a GP practice? What could we do better? What did we do really well? In level 1 of the Daffodil standards, it's about having a goal. So being able to share your vision, having maybe a meeting with your practice team to say, what ideas have you got? What are we doing well as a team that we think, not just what people are thinking, patients and carers? And then what could we do better? Because the beauty of general practice, but sometimes the difficulty is we're all doing different things. So if we could just have a common goal, increase the good for everybody that you're looking after with bereavement needs, and then finding one thing, very simple, that you could improve on, that's a gift that we can all give to patients and bereaved carers. Starting small and growing.
One of the other things I know that you're very heavily involved with is training around end-of-life care, but also around having difficult conversations, particularly when it comes to the end of someone's life. Do you feel GPs and other healthcare professionals maybe don't get enough training on this? And what sort of key bits of advice would you give to people when it comes to having these conversations?
We all, as humans, have difficult conversations every day, whether it's with our family member, whether it's maybe with other members of the team, whether it's with our patients and families. So I think one is having confidence and getting to know what your own skill set is, what you're good at, what you find easy. Try and have some awareness, whether it's through patient feedback, whether it's asking colleagues or someone that you trust, what do I not do so well? Growing that self-awareness around what you could start to do to improve. There are lots of places where you can get training, but I think that those are some of the simple things. There's a fantastic tool, again, on Daffodil Standards website, which is about having what matters most conversations. And sometimes I think we make it a bit too complicated. So yes, maybe giving a difficult diagnosis, that's a difficult conversation in itself. But sometimes it's just starting the conversation. So getting familiar with particular conversations and using language that's easy and everyday language and acceptable, like what matters most to you and your family, super way to start.
Thank you so much for your time today, Catherine. Thanks for speaking to me.
Thank you so much. It's been awesome being here. Thank you.
Catherine and I mentioned the RCGP Marie Curie Daffodil Standards Awards there in that chat, and the winners for this year's awards are due to be announced tomorrow here at the conference. So do check out our website for full details of who won those awards later on Friday. Well, that's it from this special episode from day one of the RCGP annual conference in Liverpool. Thank you so much for listening. I'll be back tomorrow with more from day two of the event, when Health and Social Care Secretary Wes Streeting will be making an appearance. So please do join me then. You can find more news and information from the conference on our website at GPonline.com/RCGP.